your trepidation about using Toradol. So I understand that because it's the most incorrectly given medication in my house, right?
Yes.
To the point where I literally hide it in the bottom of the drug box because we manage our own drug box. So I hide it in the corner of the drug box so they forget about it, right? To help quell said problem, right?
Yep.
Because sometimes it's looked at as the universal replacement for all narcotics for pain, right? And I've seen people get into always theoretical trouble with it, right? It's certainly breaking protocol and may have some spillover in clinical care, right? But the reason it kind of made my BS trauma, is really for somebody with sprain, strain, ouchie, boo boo, right? So my rule for me is if I walk in and be like, oh, that looks like it hurts, right? The Toradol's immediately out of my off my menu of available options, right?
Yeah.
If I can point it out before you tell me you hurt, then it's clearly not an option. In my mind, right? So I don't even love it for trauma, and it's very selected cases, right? It's somebody who is ambulating, dragging their leg, and you're like, oh, I twisted my ankle. Okay, I can help you with that.
So, interesting you say that. In my training, we had one of my co-residents do exactly what you shouldn't do while driving a golf cart. It was more like a dune buggy, like you roll it over and you do the natural thing of sticking your arm out and then you cripply break your arm, which is what he did. Came to the emergency department, got Dilaudid, and he got Toradol, and he said Toradol actually helped with his pain better. Yep. So I will counter that like, okay, that's an ouchie. We've got a deformity there. I've got a fracture there. I give you my Dilaudid or fentanyl. Both are fine choices. And that doesn't work. I should probably change up what I'm doing. So if I give you fentanyl, I got no change in my pain. I think it's appropriate to then, if
try something else,
blood pressure is appropriate, try something else. And then you have 3 options at that point. I tried fentanyl, it didn't work. I've got Dilaudid. I would start low on that. I've got ketamine dose. I can try that. And I've also got Toradol. So when I'm choosing which medication to give, it's based upon, honestly, more it's the side effects or not necessarily side effects, but the profile of the drug. So Toradol, think of as like super ibuprofen. It's a great medication. If you ask a patient, I say, I would take ibuprofen for it, you could consider them giving them Toradol for it. If they got a sprained ankle, it's a perfect medication to give it. Sure. And we've got good studies out there that show high-dose NSAIDs and high-dose Tylenol together are actually better for extremity pain than even giving opioids. And we all are aware of the opioid crisis and trying to reduce opioid use. And I don't want any of the providers to go out there and think, like, I want to go out there and reduce opioid use. You have them in your box for a reason. Give that opioid in the appropriate setting. You giving an opioid to a patient in a controlled instance and under your care is 100% appropriate, and that's exactly what you should do. The opioid use problem more comes into homegoing medications when patients have free access to those medications, and then they go out and seek it, and that's where the issue comes in. And again, for our adult patients that you're caring for, most of those one-time dose medications, whether it even was contraindicated, Toradol being they're in kidney failure, and you give them Toradol, one dose is probably not going to change the trajectory of what their disease is. So these are single-dose medications. Now I have to say adults because when we talk about children, we're talking about there are medications you can give that literally one pill can kill a kid just based upon their weight. And then when we do that pediatric podcast, I'm sure they'll talk about the one pills that can kill the pediatric world. But anyways, I go based upon what side effects or the asterisks are for each one. So like Toradol, we don't want to give just like aspirin, just like ibuprofen or any of the NSAIDs, it affects platelets. So it makes your platelets less sticky. You have a more higher likelihood to bleed. Contraindications for giving Toradol, in my mind, are head bleeds. I don't want to ever give it to a patient with a head bleed. If they've got a dissection, I don't want to break up any of the stickiness that I want from that standpoint. But Toradol is a fairly safe medication. We give it to patients, and they go to belly surgery all the time. Neurosurgeons use Toradol for pain, and then they go to back surgery. So it's okay. It's not that terrible of a side effect profile. But I give them if it's a hurt ankle and you try your fentanyl, Toradol would be totally appropriate because they might be like, wow, that really, really helped with that pain. Great. With the plus side that you avoided in giving an opioid. And ketamine ketamine can be the same way, that you're avoiding giving the opioid.
Yeah.
But so for me, if we're talking about trauma versus non-trauma, trauma, you're in pain, I'm going to give you fentanyl. First off the bat, it's going to be fentanyl. And the reason why I choose that is it's quick on, it's quick off. It shouldn't, not that it doesn't, but it should not affect blood pressure. If I need to give Narcan because I gave you way too much, which is exquisitely unlikely because I'm going to give her smaller doses, I can take it off with Narcan, right? So I can reverse it if I need to. So for me, fentanyl is my first go-to in a trauma. If you're otherwise not walking, but you're a normal person, your normal blood pressure, you broke your arm, it's in a sling, and I want to control your pain, I'm going to give you Dilaudid for the same reason that Scott said. It's 4 hours of pain control. I can give you a good dose. You're unlikely to drop your blood pressure. You're unlikely to stop breathing on it if I give you an appropriate dose. But if you say, if in those patients that say, I'm a recovering addict, I do not want any opioids.
My notes I was making right here. Stuff that didn't make my list that need to make my list. Go ahead.
Yep. That's very... I want to know that for my patients, and I'll tell you congratulations. I ask you how long you've been sober. I congratulate you on how many years of sobriety you have because it's very hard for them. Yes, I will avoid opioids because you don't want me to. Completely agree. Let's try Tylenol. Let's try ibuprofen. Let's try Toradol. Let's try those, and then ketamine would be my fallback.
Your finish line, yeah. And I would go one more in that box here that I have. I don't even know where this belongs on my chart, but needs to make my chart, I guess, if I'm formalizing this now, is patients that are well acclimated to opiates already.
Yep.
So whether they are a user, right, the heroin addict, not say recovering, and I've told my story
or
here
they've
before.
had 20 years of back pain, elbow pain, knee pain, and I already take 20 milligrams of Percocet every day or oxycodone, and every 6 hours I take that.
Correct.
You're not going to touch them.
Yeah, and I have 2 fentanyl patches.
Yeah, that was.
And I lick them both.
Yeah.
My case was a pancreatic cancer patient who had already had 4 milligrams of PO, Dilaudid before I got there, had taken 2 PO Percocet, and was wearing a 100 mic fentanyl patch.
Were they a hospice patient?
No. Needed to be, but they had elected not to be. And as you can imagine, just writhing in pain. What did I have in my hand? Dilaudid, because all I had at the time, right? Yeah. And ketamine would have been the better choice there, right? Much like our sicklers. Yeah. Much like us.
And for this discussion, let everyone know that 4 milligrams of oral Dilaudid is the same as 1 milligram of IV Dilaudid. Right. So it's not like oh my God, they're getting a lot. They're getting an appropriate dose. It's just 1 milligram IV. If you give them another, it'd be like doubling their dose.
Correct.
But, and something I would try and then reassess really quickly.
He got the full milligram for me, and not surprisingly, with the fentanyl and the Percocet on top of that, didn't touch him. Right, and I needed to change directions, like you had previously suggested. I didn't have at that point agents to change directions too. Right.
And the reason why we talk a lot about pain medications in that context is they actually do work very well synergistically. So I might get a little bit of this type of pain control with one med. Yeah. This works another way, and then together they actually work much better than just the two put together.
They're tailored, tailor your care.
Yep. And to that point, when I was a trauma patient, I worked myself up to 2 milligrams of IV Dilaudid Q4 hours, and every 4 hours I was asking for that because I was in a severe amount of pain. And that would only take away my pain for about 15, 20 minutes, and then I would come right back to it. Before I worked with the physicians and found multimodal pain control, which is why I talk about it a lot, to say, what other medications can you give me to then to attack my pain medication, and finding medications that work on nerves ended up almost took a lot of that pain away and reduced the number of opioids I was getting.
That was 20 years ago?
Carry the 2. 15?
11, 9. Yeah. So 15 years ago? Were tricyclics being used a lot in that time frame to augment
No.
pain? I remember that being a thing, TCAs, and to minimize.
And I think that it's borne out that it doesn't really help so much. And side effect profile into why we don't use TCAs
is right.
Very narrow therapeutic range, high risk,
exactly.
medications.
That's basically why I was asking. Is you know.
No, but I ended up being on Lyrica, pregabalin, which is sister, cousin, however you want to say it, to Neurontin or gabapentin. Yep.
Funny story. We almost had a real interesting day today because I didn't sleep very well last night. I went to take my amlodipine this morning, and I dumped it out in my hand. I went to throw it in my mouth, and I looked down, and I was like, that doesn't look right. I looked at it, and it was my dog's gabapentin. we almost had a real interesting.
You ought to use a different spot for those.
Well, she rearranged the cabinets on me, man.
The dog?
The dog, yeah.
Trying to kill you, Scott.
Yeah. But when I open the amlodipine and it's clearly gabapentin in there, then I know she's trying to off me.
Yeah.
But, we almost had a fun time today because I'd have been stoned. But
I mean, choosing the right pain medication is difficult, and a lot of it goes based upon, and maybe it's because it's complicated. You got to get used to what these medications are and what they do. You've got to be comfortable with using that medication, and that's really what kind of guides. It's your experience that guides your choice. Yeah. I mean, I can tell you what I do. You guys know what you do, but I choose fentanyl because it first for most things. Because I know it's not going to affect blood pressure. I don't have to worry about that. If I want long pain control and they're otherwise stable, I will go with Dilaudid. It might drop their blood pressure a little bit, but if they're normotensive,
that's okay.
That's okay. I might drop their blood pressure a little bit. If it goes down really bad, I can give them fluids. It'll come right back. I've never had a problem with that. Ketamine, I use as adjuncts if I failed all of my opioids and my non-opioids and they're still in a lot of pain. I will use that as adjuncts. I had a bad situation where I had an older lady that was in a lot of pain and gave her the medication. She did not have a great trip with that trip, and that's one of the side effects you have to worry about with ketamine. That it could just be a bad trip for them, and that would be not a good choice for them. And then I use a lot of Toradol when appropriate. I just consider it a super ibuprofen. If it's a medication I would otherwise give ibuprofen for, and I want to have the patient think I'm giving them a good, strong medication, which it is. It's a fantastic medication for pain. I do Toradol. I know that the protocol doesn't. We've sliced out a very specific part for Toradol, but for my own use, extremity pain, it's perfect.
It's recommended, but there's no moratorium put on other uses, right? Sure. And Ray, to your point earlier, things that I certainly tell our students is when we try to explain this is just like we're sitting here talking. It's nuanced. There's a lot to it. There's a bunch of variants. You got to walk out here basically knowing two things at this point, which is fentanyl and ketamine, right? If you can wrap your head around these for the perspective of a brand new paramedic, then you're safe, right? And you can probably cover nearly all your bases. Everything else can come with time and experience.
There's not a clear protocol or like ACLS, right? We all know our ACLS drugs. We can rattle them off. We know what to do during those cases. Pain medication, pain management's very nuanced.
Yeah, foggy at best.
Yeah, and we have a whole specialty dedicated to pain management.
Yeah.
So.
I think it's important, too, just to mention that we're not, at one point, UH took a stance, I think a lot of people did, that we were making patients pain-free. We're not shooting for pain-free anymore.
That's over.
That's over.
Thank goodness.
And thank goodness, because it doesn't do me any good to bring a patient pain-free to you in the ER and then have you try to evaluate them and say, where's your pain?
Then I have to intubate them?
Yeah, and then intubate them and everything else. So it's part of that advocacy is that it's not that we don't care for the patient, it's just not right for the patient.
No, it's not right. It's very dangerous for the patient. What I tell people is when I'm in the emergency department, and more classically with migraine headaches, I love treating migraine headaches because I can make them better. But most people, any pain that they're in, I tell them I can't take the pain away. I don't have a magic pill to take that pain away. I'm here to make it better. My goal is to make it 50% better or tolerable. Yeah. And if you set those expectations, then you're going to get a better experience to say, oh, I still have my pain. Well, what was it? Well, it's a 3 now, and well, you told me it was an 8 before. I'm where you want me to be. Let's get you to the hospital. We'll have them reevaluate you. We'll redose them their pain medication. I would love to get them pain-free, but setting that as an expectation is unattainable for most people.
Yeah. And then the other thing, too, to tail off of that is you can always redose. So I think a lot of the misconception is they're thinking this, I'm going to give this loading dose and then I'm done. And it's like, that's actually where people get in trouble. From what I have seen is they try to give too much versus I'm going to give some because I want to decrease their pain is the goal. If I can give, I'm not going to just start with 100 mics of fentanyl necessarily. I might start with 25 or 50 depending on what it looks like. But I've also walked up where that patient is significant trauma, and I went to 10 ketamine out of the gate, and I skipped fentanyl just because I thought that was appropriate. So I think we all have our own algorithms, if you will, on how we pick stuff. Were you doing that
for the hopeful side effects that the 10 milligrams is going to maybe give them a little bit of dissociation and not remember what's going on?
Yes, because they were very actively screaming. So yeah, I was like, okay, I could fix that too, and I think those are some of the things as we talk about it more, your reasoning comes out a little bit more and more why you do what you do. But you can always give more, and I think that's a big thing to explain to new providers.
Yeah.
It's okay. I think some people get in their head, well, I already gave him this, and, maybe I need to either A, switch drugs, or B, give more. Did I do something wrong? No, you didn't do anything wrong. That's actually a safe approach. So,
go ahead.
Sorry.
I was just to say, like, you guys, we talked earlier before, like, you guys are unique in that most of the time you're one-on-one with the patient. I'm covering a whole department. I might have 20 patients, 30 patients under my care at any one time. Nurses that you guys drop off to are going to be, if they're lucky, 4 patients under their care.
4 or 5 in one,
more likely 6, maybe 7. Who knows? So you guys have that one-on-one that you can really quickly, hey, I'm going to give you this. I'm going to cycle the blood pressure. I'm going to come back and evaluate that because you're giving IV pain medication is going to work very quickly, right? So you get your blood pressure before you start. You push your medication. How are you feeling? Oh, I'm feeling okay. You cycle another blood pressure. You come back to them a few minutes later. You can say, I don't feel any different. Okay, well, I tried 50 mics. I'm going to give you another 50 mics. There, I give you 100. Oh, that's not working. I'd move on to something else. But then again, if that patient's a 5-year-old kid and you just give him 100 mics of fentanyl, you should probably it's the right patient.
Reassess a lot of things.
1 per kilo.
Maybe your occupation.
But right patient, right medication,
of
right
course.
time, all that stuff. So, I mean, it's okay to give a patient 100 mics, right?
Yeah, I have before.
And you have.
Yes.
And because you have a better understanding of the medication, you have that knowledge to look at them and say, like, I can probably safely give them 100 mics right off the bat, and I don't have to go 25 or 50 aliquots to get them there, right?
Yeah.
Oh, I gave you 100 of fentanyl. That's not working. I'm going to go to something else now. And I'm going to go there very quickly because you're in a lot of pain. I want to get you more comfortable, and I want to treat your pain, but that comes with
time and experience.
Yeah. You walk up on a 150 kilo patient to 200 kilo patient. You're like, okay, I'll come heavy.
Yeah, exactly.
And I'm still way under 1 mg per kg, right?
Versus that 90-year-old, 90-pound patient that just fell and broke their hip. I'm not going to come in as heavy. I'm going to build on it. I'm going to that would be a situation where I would approach in steps. Yeah. That's just me, because my take.
Building off of his setting realistic expectations, right?
Yeah.
I also do some psychology tricks to basically set them up for this is going to help, right? Sure. I don't give them an option of this might help, right? I give them an out to second guess my therapy or anything like that. This is going to help, and then just quick little fun play on that. We had a patient one time was just screaming in pain. I'm going to give you this. It's going to help. We wound up giving like 50 mics of fentanyl, starting pretty standard starting dose. And I wound up driving. We're driving down the road, and where's his pain at now? And my partner goes, how's your pain now? He goes, it's 0. And I about crashed the truck because I think that's like the only time in my career, because I was waiting for
the patient's 0.
7, right? And I'm like, what? Did he say 0? Like,
Or you
no
can try
pain.
to use that new exploratory
No
drug,
pain.
the new one out there, the normaceline.
The
Usually works
normaceline.
great.
We carry transdermal normaceline. We put 4 of them on every patient. So
Even built in right to your
it's
leads,
built,
right?
yeah, no, you can monitor right through them.
Right.
Yeah, no, it's only the best for our patients, man. It's
Well, to your point, though, that does go a long way, and probably one of the reasons why I do like treating headaches so much, because I'm very confident going in and saying, I can fix this, I can make this better, but I'm not going to get you 100% of the way there. I have my medications that I think I work really well, and I tell them that I've only had 2 people that have failed my treatment out of the hundreds, thousands of people I've tried.
Yep.
So, but yeah, going in and saying, I can make this better.
Yep. But
does
not,
go a
but,
long
but
way.
yeah, but
Make better,
making sure,
not go away.
I
Right.
can't make it go away, but
Correct.
you know, this is going to help
Right.
in some capacity. The other thing I do, which is for multiple reasons, mostly to make sure that I don't push some big slug of any drug into my patient's circulatory systems, I dilute everything. So I wound up coming at them with with a big syringe, right? So it looks like I'm giving them a lot. And then when you push that really, right, exactly.
50cc syringe coming.
Big 16 or just like that. You know, there's also psychological benefit for the patients there as well, right?
I didn't think
You
about
draw
that.
it up with a 14 gauge just to be like, look, it's a big needle.
Always
It's really-
correct. It's and all dosing is always in micrograms because it's a bigger number, right?
I just milked the fentanyl rock.
I'm going to give you 500 of Dilaudid.
Yeah,
500? 500, yes.
Whoa.
500 mics. But, you know, it's, just, I'm giving it diluted for patient safety, but of course, to them, it looks, like a big 10 ml syringe, like, you're just giving a bunch of it. So there's more than just the pain to pain, right?
A lot of it goes back to just talking to your patients. We
Yeah.
talked about that a little bit off camera, touching your patients and doing good treatment and care. And a lot of it is just communication, talking to them through their situation. Even some medicine, you calm them down. The majority of the time, it's going to decrease their pain.
Well, and that's to your point. If you ask them, like, this is pain they've had before. Like, first off, it's kidney pain. Oh, this feels exactly like my
my
prior
last
kidney
one,
pain. Great.
It's probably
going to be kidney pain.
That's probably kidney pain.
What did they give you last time?
Yeah,
Or
and
in the
what
hospital,
worked?
They gave me Toradol. That worked great.
Okay.
Sweet.
Start here.
I've got that. I'm going to give you Toradol. There's no reason they're trying to reinvent the wheel and go down your algorithm of I'm going to do 50 of fentanyl, then another 50 of fentanyl. That doesn't work. I'm going to give a 0.5 milligram of Dilaudid. And if that doesn't work, I'm going to give.
Right.
Just ask them. Obviously, that does be aware of the possibility for abuse. They're like, oh, the only thing that works
Only thing that works
is
is
a
the one that
milligram
starts with a
of
D.
Dilaudid.
Starts with a D.
And
Dilaudid.
I get a little itchy with it, so we have to push Benadryl afterwards. Yeah, we all know those tricks. Be weary of that. But if it's a reasonable person who's in a lot of pain, they're like, look. And if you, calling from my own personal experience, when I was a patient and in the ICU, I, for the longest time before going to medicine, listed morphine as a allergy. And you would all look at a patient like, you have morphine listed as an allergy. Why is that? Why is that, sir? Yeah. And the reason why I started listing it, and I also listed Ativan, was because of my experience in the hospital. Morphine, for me, I become angry if I'm on morphine. So that's the reason for my allergy that I used to list. I used to list Ativan because I didn't know any better, because when they decided to take me from the ICU to a PICU, and this was before most computer systems were good, they stopped me cold turkey after 4 weeks of a Ativan drip. So I went into fluid benzo withdrawal on a step-down unit. So I became tachycardic and hypertensive, and I thought, oh, this is an allergy. No, I was in benzo withdrawal.
Sure.
So. But and the reason why I say that is that all your patients aren't in medicine. They don't know that. So if you talk to them and you can get a better understanding of where they're coming from or what they want. So if you come across the prior me before I was a doctor, I said, I didn't take morphine because I was really angry with it and I was mean to people, but I was okay with Dilaudid, Q2 milligrams, Q4 hours. That story makes a little better sense. I'd be like, okay, well then I might just lean towards the Dilaudid because I know that that's worked for you in the past. Or they're on 4 milligrams oral Dilaudid.
Right, yeah. And we were talking off camera a little bit about, I know in your case and in my case was a spontaneous pneumothorax, but until I experienced real pain, right? How I medicated people prior to that is way different.
You've changed.
I absolutely have changed, because now you've lived that real, right? You've lived that real time, right? I was like, oh no opiates, and then as they're sliding the chest tube in with just some Toradol on board, which in case you haven't figured out, it's a bad idea. Of course, this subsequently changed my opinion on this. Let me have the Percocet, and then I was on the morphine drip in the ICU after I came out of the. Because I did go to surgery to have a blebectomy, and I think it was only 2 or 3 days on a morphine drip, but again, that changed my mindset on what true pain is, and why it's important for us to do it when we can and when it's appropriate.
When it's appropriate, right? And if you're a new provider out there watching this and you haven't had that experience, talk to the more experienced guys and gals that you work with to say, like, what would you do in this situation, or how would you approach this? Because they probably have experience personally, or that they had a family member or some history to help guide you in what your selection is going to be.
Absolutely.